Hello everyone, this is Andy Brokenbrough and welcome to Nephrology Bootcamp. The Northwest Kidney Center appreciates your willingness to learn more about caring for dialysis patients. Today we'll be talking about the management of anemia or a low red blood cell count and why it is such a big problem among dialysis patients. Managing anemia is an important job of dialysis units, so it's important for anyone who works in the dialysis field to be familiar with anemia and its treatment. Anemia is extremely common among hemodialysis patients. It's responsible for many of the symptoms associated with chronic kidney disease, including fatigue, reduced exercise tolerance, shortness of breath. Anemia is also associated with heart problems and an increased risk of hospitalization and hospital length of stay. So there are a lot of reasons to understand and treat this problem. Today's talk has 4 objectives. First, we'll define anemia. Second, we'll review causes of anemia among dialysis patients. Third, I want you all to be familiar with the management of anemia, and that includes erythropoiesis stimulating agents such as Mircera, as well as intravenous iron. And finally, we'll review the side effects of erythropoietin stimulating agents as well as intravenous iron. Let's begin with some general background on anemia. Anemia is a reduction in hemoglobin or a reduction in number of circulating red blood cells. For people with normal kidney function, the World Health Organization, or the WHO, defines anemia as a hemoglobin less than 13 for adult men and less than 12 for premenopausal women. Now, anemia is not specifically defined for dialysis patients, although the generally accepted goal is to keep the hemoglobin above 10. Anemia was first linked to kidney disease over 170 years ago by Richard Bright. Richard Bright was an English physician who did research into the cause and symptoms of kidney disease. He's known as the father of nephrology. And some of you may have heard the term Bright's disease. We don't use it anymore, but it describes what modern medicine calls acute or chronic nephritis, generally characterized by swelling, the presence of albumin in the urine, and it's frequently accompanied by high blood pressure and heart disease. So it's an old term, but a nod to his contribution to the field. Nearly all patients who are on dialysis are anemic. There are many complications of anemia and end-stage renal disease. The ones we know about for sure include fatigue, shortness of breath, the need for blood transfusions. Other complications include likely reduced quality of life. Anemia is accompanied by fatigue, which can really limit activity. Possible complications include increased cardiac events, heart attacks, thickening of the heart muscle. We call that left ventricular hypertrophy. Okay, let's first talk about the causes of anemia in dialysis patients, and there are many. So for starters, dialysis patients can lose blood. It's a very common problem. Second of all, dialysis patients oftentimes have nutritional deficiencies such as iron and folate and B12. Chronic inflammation, which is highly prevalent in dialysis patients, also can contribute to anemia. And finally, the most important of all is something called erythropoietin deficiency. We'll talk about this in detail, but essentially the kidneys make a hormone called erythropoietin, which stimulates red blood cell production in the bone marrow. In most dialysis patients, the underproduction of erythropoietin is the main reason for anemia. Okay, first let's talk about blood loss. Dialysis patients lose blood with the dialysis procedure. For example, some blood remains in the filter and in the tubing, the so-called dialysis circuit, at the end of the procedure. Dialysis patients undergo frequent blood draws. They can also lose blood from their fistula, especially after the needles are withdrawn or before clotting occurs. Gastrointestinal bleeding is also very common. Dialysis patients receive heparin with the dialysis procedure, and many dialysis patients use other blood thinners or anticoagulants such as aspirin or warfarin. This is one of the main reasons why dialysis patients often lose blood through their gastrointestinal tract. In fact, GI bleeding is 100 times more common in dialysis patients than in the general population. Premenopausal women often lose blood every month with menstruation, and this contributes to anemia as well as iron deficiency. Okay, nutritional deficiency, a very common problem among dialysis patients. Dialysis patients, they're always making new red blood cells, and this process consumes a lot of nutrients, such as iron and folic acid and B12. The most important of these is iron. Iron deficiency is very common among dialysis patients because so much iron is used in the process of making red blood cells. And dialysis patients make a lot more red blood cells than the general population because red blood cells have a shortened lifespan among dialysis patients. As an aside, it's very important to administer iron intravenously during the dialysis procedure rather than orally. Here is a study which basically showed that oral iron was no better than placebo in supplementing iron in dialysis patients. In other words, the absorption of oral iron is so poor in dialysis patients that you might as well not give it at all. Folic acid and B12, these are B vitamins, water-soluble vitamins which are lost during the dialysis procedure, but are essential for red blood cell production. This is one of the reasons why we prescribe renal vitamins to our patients. So if patients don't take a renal vitamin or have a poor diet, then they can become deficient in folic acid and B12, and this can impair red blood cell production on the basis of nutritional deficiency. Okay, inflammatory block is a big cause of anemia in dialysis patients. So what is it? Well, inflammation can be caused by basically any illness, including end-stage renal disease and all the health problems that our dialysis patients have. And illness, for whatever reason, is a stress on the body. This revs up the body's immune system in a process called inflammation. And inflammation negatively impacts the body's ability to make red blood cells. Inflammation is probably responsible for about 20% of all the anemia in dialysis patients. So in other words, kidney failure and the dialysis procedure are associated with a chronic state of inflammation, and the body does not make red blood cells well in the setting. Why does this happen? Well, for starters, uremia is thought to occur as a result of accumulation of waste products in the blood, and there are probably some uremic inhibitors of red blood cell production. One of these is called a protein, an inflammatory protein called hepcidin. So we're going to talk about that. Hepcidin was discovered in 2000. It's a protein in humans. It is synthesized by the liver. Interestingly, it's a key regulator of the entry of iron into the circulation or the bloodstream in mammals. So basically, there are significant iron stores inside of cells, but the iron needs to be able to leave these cells and go into the bloodstream, where it will then travel to the bone marrow, where it can be used as a building block to make red blood cells. Hepcidin reduces the extracellular iron, that is the iron outside of cells available for red blood cell production in the body by several mechanisms. And this is a bad thing if you're trying to make more red blood cells. So how does hepcidin keep iron out of the bloodstream? Well, there are several mechanisms. For starters, Hepcidin decreases the absorption of iron in the intestines. And this is one of the reasons why oral iron is not well absorbed in dialysis patients. Second, the liver has lots of iron stored inside of its cells, and hepcidin reduces the ability of iron to leave the liver and go into the bloodstream. There are also cells in your body called macrophages, which contain a lot of iron, and hepcidin prevents iron from leaving these cells as well. So both the liver and macrophages, which are a type of white blood cell, are part of something called the reticuloendothelial system and are significant storage areas of iron in our body. Okay, so how does hepcidin do this? How does it prevent iron from going into circulation? Well, when the body is inflamed, the liver responds by making more of these inflammatory proteins, including hepcidin. It turns out that hepcidin binds to a channel inside of the cell membrane of cells like the liver and the macrophages. And this is a channel by which iron leaves the liver cells and macrophages. But when hepcidin binds to that channel, both the hepcidin and the channel are taken up inside the cells, and you lose the channels that allow iron to leave the cells. So why in the world am I talking to you about hepcidin? Well, for starters, hepcidin inhibitors are currently being studied as a possible treatment for anemia of inflammatory block in dialysis patients. So we may see these in the near future. Also, there is a genetic condition you may have heard of called hereditary hemochromatosis. This is a very common condition. About 1 in 12 people who are descendants of Northern Europeans carry one copy of the gene, and about 1 in 150 people carry two copies of this gene. In this condition, hepcidin production by the liver is low, so that you actually have too much iron in the bloodstream. Iron then deposits in other tissues, such as the heart and the pancreas and joints, and this leads to damage from iron accumulation. So why do we need to know this? Aside from being interesting trivia, it's because we sometimes see an analogous condition in dialysis patients, not because of the genetic abnormality, but because we can sometimes cause iron overload in our dialysis patients if we give them too much intravenous iron. And we will talk more about this shortly. Okay, so now the last and most important cause of anemia in dialysis patients is due to a deficiency in a hormone called erythropoietin. Okay, so erythropoietin is a hormone produced by the kidney, which stimulates red blood cell production in the bone marrow. Erythropoietin levels in dialysis patients are typically only 1 to 10% of values found in people with normal renal function. And erythropoietin deficiency is responsible for about 80% of anemia in the dialysis population. Again, about 20% of anemia in dialysis patients is, quote, resistant, end quote, to epogen for various reasons, and inflammation is probably the main factor. Okay, so there's a history to erythropoietin. In 1904, Paul Carnot, he's a professor of medicine in Paris, first proposed the idea that there must be a hormone in the bloodstream that regulates the production of red blood cells. And the way he proved this was by bleeding rabbits. So essentially he took a group of rabbits, he bled them down to the point that they were very anemic, and then he took blood from the anemic rabbits and infused it into another group of rabbits. And the second group of rabbits then developed really high red blood cells in their blood. In other words, the anemic rabbits underwent a procedure of essentially transferring their blood, something in their blood that stimulated the normal rabbits to make more red blood cells than usual. So that's how we first figure out that there must be a circulating factor that stimulates red blood cell production. But it wasn't until 1977 when a researcher named Miyake was able to isolate erythropoietin from 2,500 liters of urine from patients with a severe form of anemia called aplastic anemia. And this allowed for the subsequent identification of the gene that encodes for erythropoietin and then the production of this compound commercially. In 1987, Joe Eschbach, a nephrologist who worked at the Northwest Kidney Center, conducted the first clinical trial of Epogen. And I think it's just amazing that the first Epogen trials were conducted at our organization. In 1989, Epogen received FDA approval. Okay, so this is a picture of Joe Eschbach. He published a couple of landmark papers using erythropoietin. First, in 1987, he did a study of 25 Northwest Kidney Center patients who were given erythropoietin and reported that no further transfusions were needed. And this is a huge breakthrough because most dialysis patients up to this point were transfusion dependent or needed to be transfused blood on a regular basis during dialysis. He also published a phase 3 trial of 333 hemodialysis patients with hematocrits less than 30% who were given Epogen. Their mean hematocrit increased from 22 to 35%. And basically the transfusion rate decreased from over 1,000 in the previous 6 months to virtually none. So this basically, the introduction of recombinant erythropoietin basically replaced the need for blood transfusions in dialysis patients. Okay, so why is it such a great thing to avoid blood transfusions? Well, for starters, there's always a risk of infection, particularly hepatitis B and other bloodborne viral infections through a blood transfusion. Second of all, if you transfuse a dialysis patient, they may develop antibodies to common proteins in the blood, which may make it harder to find an immunologically matched kidney transplant. This is called sensitization, and if your dialysis patient becomes sensitized to common proteins, then it becomes very difficult to find them kidney transplant. And finally, prior to the introduction of erythropoietin, many dialysis patients develop what was called iron overload syndrome. So blood transfusions contain a lot of iron, and if you receive a lot of blood transfusions, your bloodstream level, iron level can rise significantly, and then this can deposit in major organs such as the liver, the pancreas, the heart, the pituitary, and this produces the same clinical picture as the genetic condition we discussed a little bit ago called hemochromatosis. Okay, so back to erythropoietin. Erythropoietin is a circulating hormone that has many effects beyond just raising red blood cell production. These include wound healing, the brain's response to neuronal injury, vasoconstriction or tightening of the blood vessels. Erythropoietin can stimulate the growth of blood vessels. We call that angiogenesis. It can stimulate the proliferation of smooth muscle fibers. Increases intestinal iron absorption, probably improves memories. There are several studies that have demonstrated an increase in activity in a part of the brain called the hippocampus, which affects memory. And it also may have effects on mood. Okay, erythropoietin blood levels. So basically they're very low in the absence of anemia, but they can increase 1,000-fold or even 10,000-fold under hypoxic stress. So if you don't have enough oxygen in your blood, your body will make a lot more erythropoietin. This is why patients with lung disease often have very high hemoglobin levels. Now there's one exception. Erythropoietin blood levels tend to be very low in patients with polycystic kidney disease and patients with renal tumors. And these patients oftentimes have relatively robust hemoglobins on dialysis and don't need erythropoietin. Okay, so recombinant human erythropoietin is also known as Epogen alpha. It's produced in this country by Amgen, and it is a very expensive medicine. As of 2010, it was a single greatest drug expenditure paid by Medicare. They spent $2 billion on that medication alone in 2010. I couldn't find more current estimates, but the point is the federal government is very aware that it spends a lot of money on this medication, money on this drug. Okay, so now let's shift gears and talk about the management of anemia. So we screen all patients. Okay, so on a practical level, how do we manage anemia in dialysis patients? Well, for starters, we screen all dialysis patients for anemia upon initiation of maintenance dialysis with a CBC, or a complete blood count. Hemoglobin is then monitored at least monthly. In addition, we check hemoglobin whenever it's clinically indicated, such as after a major surgical procedure or a hospitalization, or if they had bleeding, say, from their axis after a treatment. Generally, we don't start erythropoietin until the hemoglobin is less than 10, and a target hemoglobin typically is between 10 and 11 based on consensus opinion, although the optimal target hemoglobin for dialysis patients is not entirely known. We have two main tools with which to treat anemia in dialysis patients. These are erythropoiesis stimulating agents, or ESAs, and intravenous iron. And there are actually several different types of each which are available, and we'll discuss these next. Remember that the goal of treatment is to reduce the likelihood of needing a blood transfusion and to mitigate any symptoms due to anemia, such as fatigue. So, for example, improve quality of life symptoms, improve exercise tolerance. There are now several different erythropoiesis stimulating agents, or ESAs, available on the market. The prototype is epoetin alpha, manufactured by Amgen, approved by the Food and Drug Administration for use in dialysis patients. But there are others too. For example, erythropoietin alpha EBX. Basically, it's a biosimilar of erythropoietin alpha. Biosimilar is a biologic product that is highly similar to and has essentially no clinically meaningful differences from an existing FDA-approved reference product like erythropoietin alpha. And biosimilars were approved by the FDA in 2018 for the treatment of anemia of chronic kidney disease. Basically, the approved dose is exactly the same as this for erythropoietin alpha. The physiologic effect is the same. There are longer acting ESAs, including darbepoetin. It's another form of recombinant human erythropoietin. Basically, it's got a big molecule. It's oligosaccharide chain on the N terminus. And because it's such a big molecule, it's cleared from the circulation more slowly, so it has a much longer half-life, and therefore it has increased biologic activity. It's produced by recombinant DNA technology, I think using modified Chinese hamster ovary cells. It's been approved for the past 20 years for the treatment of anemia in patients with kidney failure. It can be given intravenously or subcutaneously. Another long-acting option is Mircera, which we currently use at the Kidney Center. Mircera is a long-acting ESA. It was FDA approved in 2007 and became available in the United States in 2015. Kind of like the darbepoetin, basically it's manufactured by taking erythropoietin, in this case beta, and then linking a very large side group, methoxy polyethylene glycol butanoic acid, to that molecule. So it's a very big molecule, so it's harder to remove from the circulation. It has decreased affinity for the erythropoietin receptor, but a much longer half-life. And it's been used at the Northwest Kidney Center since 2018. Okay, so this slide shows the differences in half-life for some of the different agents. So basically the half-life for EPO alpha is about 7 hours, for Aranesp about 25 hours, and for Mircera is about 130 hours. So basically you can increase the half-life of EPO alpha with this side chain so that it's 20 times greater. So it lasts for several days in the plasma, which is why it can be dosed every 2 to 4 weeks. Okay, fun fact, July 17, 2008, the Italian bicycle rider Riccardo Rico was disqualified from the Tour de France because the urine sample tested positive for Mircera. So, unfortunately, these medications have been abused by athletes who want to increase their ability to deliver oxygen to their tissues by making more red blood cells. So Mircera and ESAs are incredibly important tools in managing anemia in dialysis patients, but they don't work unless you have enough iron available. So as mentioned earlier, iron is one of the main building blocks of red blood cells. In general, it's important to administer intravenous iron either before or along with the ESA. General indications for intravenous iron include a transference saturation of either less than 20% or 30%, depending on the protocol, and a ferritin of less than 200, although the current Northwest Kidney Center protocol just uses the transference saturation as the indication for iron replacement, essentially to achieve a target transference saturation of 30 to 50%. So the TSAT, or transference saturation, is calculated by dividing the serum iron by the total iron binding capacity. And that basically corresponds to the amount of circulating iron that you have. It's a good indicator of the soluble iron in the bloodstream that's available for use by the bone marrow. In contrast, ferritin is a better indicator of total body iron stores. That is, how much iron is stored in tissue, such as the liver. There are many different intravenous iron preparations available on the market. These include Ferlicit or sodium ferric gluconate. This is what we use here at the Northwest Kidney Center. Another option is Venofer or iron sucrose, and we sometimes give that to patients who have had adverse reactions to the Ferlicit. Ferumoxytol is a form of intravenous iron that can be given in a large dose as an IV push, so over a short interval like 10 seconds, which is very convenient from an administration standpoint, although we don't use it here at the Northwest Kidney Center. Another one is ferric carboxymaltose. And honorable mention goes to iron dextran, which has been around the longest. There are both high and low molecular weight preparations of iron dextran, and we prefer the low molecular weight preparations. And that's because the high molecular weight preparation is associated with a high incidence of anaphylaxis, up to 2%, as well as other adverse reactions, and generally not given anymore. Some of you who have given it before probably remember having given people a test dose of the iron dextran, followed by a slow infusion. We usually administer intravenous iron as what's called a loading dose when trying to correct iron deficiency. And there are many different regimens possible. Most involve giving iron in incremental doses up to, say, 500 milligrams or 1,000 milligrams. So, for example, you could give iron sucrose or Felicit 100 milligrams IV every treatment for 10 treatments if you wanted to give someone a gram of iron. The purpose of the maintenance dose of iron is to make sure that we maintain adequate stores of iron to prevent iron depletion. So essentially, most dialysis patients need supplemental iron on a continuing basis. And lots of randomized controls have demonstrated that you need less erythropoiesis stimulating agent when you give more iron. The optimal iron regimen for maintenance therapy is unclear. The current Northwest Kidney Center protocol is to administer Ferlicit 125 milligrams intravenously every month. So here are the specifics of the Northwest Kidney Center intravenous iron protocol. For transferrin saturation of less than 20%, we administer Ferlicit 125 milligrams every treatment for 6, and then we go to a maintenance dose of 125 milligrams monthly. If the transferrin saturation is between 20 and 30%, we give 125 milligrams of Ferlicit for 3 treatments, and then the maintenance dose of 125 milligrams monthly. If the transferrin saturation is already between 30 and 50%, we give the monthly maintenance dose. And if it's greater than 50%, we hold intravenous iron. So we know that we can increase hemoglobin with a combination of an erythropoiesis stimulating agent and intravenous iron. But what should be our target hemoglobin? In 1989, we treated hemoglobin from an average of 7 grams per deciliter up to a target of around 10 grams per deciliter. But in the 1990s and 2000s, there was great interest in normalizing hemoglobin. That is, increasing the hemoglobin to 13 grams per deciliter or more. But we don't do this anymore because studies have shown that this has been associated with a number of adverse outcomes, including increased risk of cancer, heart disease, stroke, and access thrombosis. One of the best studies to show that normalizing hemoglobin could be harmful to dialysis patients is the normal hematocrit trial. This was published in the New England Journal of Medicine, 1998, by Bessarab et al. In this study, over 1,200 dialysis patients with cardiac disease, so either heart failure or heart attacks, who had a baseline hemoglobin between 9 and 11 on epogen, were randomly assigned to achieve and maintain a hemoglobin of either 14 or 10. The study showed that there were more adverse events in the high hemoglobin group. So those who had a hemoglobin of greater than 14 had greater risk of the combined endpoint of death or non-fatal heart attack, there was a 7% higher 1 and 2 year mortality rate, and there was greater risk of access thrombosis and a greater risk of hospitalization. Okay, so in addition to these data, which were limited to hemodialysis patients, a number of other randomized controlled trials have been performed, mostly including non-dialysis CKD patients, and most suggest that targeting higher hemoglobins with ESAs does not lower mortality and actually increases cardiovascular risk as well as the risk of malignancy. So, for example, PARFRE looked at nearly 600 dialysis patients. There was an increased stroke risk if you normalize hemoglobin. Drucadol, 600 CKD patients trend towards increased mortality with higher hemoglobin. SING, CKD, no benefit to higher hemoglobin with increased cardiovascular risk. And finally, Pfeffer looked at a study in the CKD, the non-dialysis population. There was no clear benefit to a higher hemoglobin, and there was an increased risk of stroke and cancer deaths. Okay, so why are the adverse side effects? Well, it's probably because that it's likely anyway that supraphysiologic doses of erythropoiesis stimulating agents, especially in very high doses or in patients resistant to treatment, have effects on other tissues. So again, there are receptors for epogen on the heart and blood vessels and the brain, etc. But you know, we know that that giving anything in massive supraphysiologic doses has the potential towards untoward effects, and that's why there's been a renewed interest in finding alternatives to epogen. More of that to come in the future. Okay, so our current understanding, targeting hemoglobin above 13 is harmful. A hemoglobin of less than 10 is probably associated with diminished quality of life just because of shortness of breath and fatigue. So in general, we try to keep the hemoglobin between 9.5 and 11.5, likely to be both beneficial as well as safe. But no treatment is entirely safe. Every medicine has potential side effects. So there is always a potential downside to treating with medications, and erythropoietin and intravenous iron are no exception. Erythropoietin has several potential side effects, some of which we discussed earlier. These include an increased risk of hypertension, increased risk of blood clots in the veins, including access thrombosis. So grafts and fistulas are more likely to clot when patients receive higher doses of an erythropoiesis stimulating agent. Higher doses of erythropoiesis are associated with increased tumor growth in patients who have cancer. And as we discussed earlier, there's an increased risk of heart attack and stroke, heart failure, and death if the hemoglobin is increased too high, say to 13 grams per deciliter, as we discussed a little bit ago. Intravenous iron is associated with many side effects, including nausea. It's one of the most common side effects that we see. It's common with intravenous iron, particularly if it's administered too quickly. It's one of the main reasons why we inject it slowly over the course of the dialysis treatment rather than as a single bolus. Dialysis patients can also have non-allergic reactions to intravenous iron. These include a rash or hives, a skipped heartbeat or palpitations, dizziness, neck and back spasms. Dialysis patients can also have an allergic reaction called anaphylaxis. This is a severe reaction that can include difficulty breathing, itching, a rash over the entire body, and the risk is highest with that old preparation of intravenous iron called iron dextran, and it's lower with the newer agents such as Ferlicit, ferumoxytol, and Venofer. Another potential complication of intravenous iron administration is iron overload. So we talked earlier about the problem of iron overload, which is a condition of increased body iron content and consequent signs of organ damage. There are several organs in which iron can be deposited, causing ill effect. It can occur in the liver and cause cirrhosis. Iron deposition of the pancreas can lead to diabetes. Iron can also deposit in the skin and render the skin sort of a tan discoloration. Iron can additionally deposit in joints, leading to arthritis so bad that it requires joint replacement. Another severe complication of iron overload is heart failure if iron deposits within the musculature of the heart. Studies in dialysis patients suggest that the liver iron content is increased compared to reference values in the majority of patients. So we definitely increase the iron burden in our dialysis patients by administering intravenous iron. Another potential complication of intravenous iron administration is something called oxidative stress. This results from an overproduction of reactive oxygen, nitrogen species in cells and tissues, leading to oxidation of proteins and other macromolecules. Intravenous iron is thought to promote oxidative damage of DNA, say of white blood cells, as well as cells lining the blood vessels called endothelial cells, which can lead to dysfunction of these vascular cells. And there was some concern that this may contribute to the high cardiovascular disease prevalence that we see in dialysis patients. Additionally, ferritin levels rise when we administer intravenous iron. Ferritin is also elevated in states of inflammation, and it's considered an inflammatory marker. Now, in the general population, high serum ferritin levels are associated with an increased risk of heart attacks and the development of plaque in arteries, such as the carotid arteries. In dialysis patients, the association between ferritin levels and outcomes is not entirely clear, so some studies are needed, but there is concern that the administration of intravenous iron, in theory, could contribute to the bad cardiovascular outcomes in dialysis patients. There may also be an increased risk of an infection associated with intravenous iron administration. The theory behind this is that iron is a substrate for bacterial growth. The current Northwest Kidney Center protocol says to hold administration of iron in the setting of an infection. So specifically, hold IV iron if a patient has an infection requiring intravenous antibiotics. If the patient's still receiving IV antibiotics more than 2 weeks, then you can resume the IV iron. So at least a 2-week period of the infection, our current protocol is to hold intravenous administration of iron, given concern that we could potentially negatively impact the treatment of that infection. Several studies in dialysis patients have looked at the risk of infection associated with high ferritin and intravenous administration of iron. Several studies, 9 in particular, have showed that high ferritin is associated with a higher incidence of infection or infection-related mortality, whereas 4 studies did not show this association. And the administration of IV iron in 12 studies was associated with higher risk of mortality, whereas in 10 studies it was not. One study suggested that bolus dosing of intravenous iron is associated with a higher risk of infection than maintenance dosing for patients with a catheter. One of the larger studies to look at this issue is called the DECIDE ESRD study. It's an observational study of dialysis patients in DCI clinics that looked at the association of intravenous iron use and hospitalization. There were almost 10,000 dialysis patients enrolled in the study. And what the authors found was a higher cumulative dose of intravenous iron was not associated with all-cause or cardiovascular or infection-related hospitalizations. Additionally, there was no association between the intravenous iron administration and dose and the risk of infectious events at 1 month, 3 month, or 6 month intervals. Another study published by ZIT was a prospective observational study looking at intravenous iron use and the risk of mortality. There were 235 incident dialysis patients who received intravenous iron supplementation. And interestingly, iron supplementation in this study was actually associated with a significant reduction in all-cause mortality, as well as marginally lower cardiovascular and sepsis-related mortality. So, in summary, the studies that have looked at the risk of infection and hospitalization and cardiovascular mortality associated with the use of intravenous iron are inconclusive regarding an association. Most data are derived from observational studies in dialysis patients, and that is subject to confounding. And so there are very few randomized controlled trials conducted to date that were of sufficient duration or sufficient power to assess for the risk of infection. The current advisory board, the Kidney Disease Improving Global Outcomes, or the KDIGO organization, essentially recommends avoiding intravenous iron use in patients with an active systemic infection, but otherwise giving it as we do according to our protocols. Okay, now I'd like to take a break from this didactic discussion and run through a number of clinical cases of anemia management. All of these cases are based on real life scenarios. Okay, so the first case, a 24-year-old man starts dialysis. His hemoglobin is 8.3 grams per deciliter. Transferrin saturation is 14%. Ferritin is relatively low at 68. How should you manage this patient's anemia? Option A, transfusion as soon as possible. B, start Mircera. D, start intravenous iron. Or D, both B and C. So the answer that I chose is both B and C. It would be perfectly fine to just do C and see what happens, because oftentimes when we give people intravenous iron, the blood count comes up. But he's on dialysis, probably will need Mircera at some point anyway, so I usually just start both together. So we know that the hemoglobin less than 10 warrants treatment, so we want to do something. The transferrin saturation is less than 20%, and the ferritin is less than 200, so he is relatively iron deficient and needs intravenous iron. Transfusion is generally reserved for a hemoglobin of less than 7 and symptoms, so that would not be the first choice here. Okay, the next case, an 82-year-old man who has been on dialysis for 3 years, has a hemoglobin of 10.5. It's been stable there for several months on Mircera, 30 micrograms every 2 weeks. But this month his hemoglobin is low at 8.3. So we check it a week later and it's now 7.2. How do you manage this person's anemia? So option A, transfuse as soon as possible. B, increase the Mircera all the way up to the maximum dose of 200 micrograms every 2 weeks. C, check iron levels and give more iron if needed. Or D, call the nephrologist for guidance. So the answer that I chose in this case is D, to call the nephrologist. It turns out that this patient had black stools, and this suggests the presence of blood. Blood on the stool contains iron, which oxidizes when exposed to air and turns the stool black. And the iron studies were then checked, and he was found to be iron deficient because of a gastrointestinal bleed, and he was sent to the hospital, underwent an upper endoscopy, and was found to have a gastric ulcer. Okay, next case. 50-year-old woman has a hemoglobin of 8.4 on Mircera, 150 micrograms IV every 2 weeks. She was recently hospitalized for pneumonia. Her transferrin set is 6%. Ferritin is 1200. How should you manage this patient's anemia? So option A, you can increase Mircera to, again, the maximum dose of 200 micrograms IV every 2 weeks. B, you can hold Mircera because she's receiving antibiotics for pneumonia. C, you can give more intravenous iron. or D, you can continue current management. Okay, so the option that I chose is D, continue current management. So just some comments about this case. So the transferrin saturation is low at 6%, but the ferritin is very high at 1200. This is consistent with inflammatory block. Essentially, the patient's very inflamed, producing hepcidin. The iron gets trapped inside of the cells like the reticuloendothelial cells, and the liver cells can't get into the bloodstream, so there's very little blood actually in the bloodstream that can go to the bone marrow for making red blood cells. But as the underlying infection resolves, the hepatic production of these inflammatory proteins such as hepcidin will decrease, and the patient will then again have access to intracellular iron stores. More recent studies suggest that intravenous iron does not negatively impact the clinical outcome when patient is being treated with antibiotics for an infection. But again, our protocol at the kidney center is to hold the iron for 2 weeks while the patient is being treated. Finally, we could increase the Mircera to 200 micrograms. But again, if you don't have enough iron to respond to the Mircera, it wouldn't do any good. It would just increase the cost of their therapy. Okay, the next case is a 30-year-old man with a hemoglobin of 7.0, transferrin saturation of 14%, and a ferritin of 807. He has been receiving incrementally larger doses of Mircera. Now he's getting 200 micrograms every 2 weeks without improvement. He misses dialysis frequently. How should you manage this patient's anemia? A, increase Mircera to 200 micrograms weekly, so give it even more often. B, arrange for transfusion. After all, the hemoglobin is only about 7, and that's usually our threshold for giving blood. C, give more intravenous iron. After all, the transferrin saturation is below 20%. Or D, encourage more regular dialysis attendance. So the answer that I chose is D. Basically encourage the patient to attend dialysis more regularly. So if a patient misses dialysis frequently, then what happens in their blood is the accumulation of waste products, and these are pro-inflammatory and essentially cause an inflammatory block anemia. Again, sort of a classic picture of a low transferrin saturation and a high ferritin. That pattern is very common among anemic dialysis patients. More iron would just increase the likelihood of iron overload in their tissues. No transfusion is needed even with a hemoglobin of 7, in part because of the patient's youth, but also in part because such a young patient would likely be a good transplant candidate given his young age. And again, giving someone blood or exposing them to blood exposes them to common proteins against which they can make antibodies, so it could make matching a kidney difficult in the future. Okay, the next case, a 70-year-old dialysis patient has a hemoglobin of 13 despite discontinuation of Mircera and intravenous iron. What do you recommend? Option A, resume Mircera at 30 micrograms IV every 2 weeks, because if you don't, his hemoglobin will likely fall and he will become very anemic next month. B, give more intravenous iron. Or C, call the nephrologist for guidance. And in this case, I chose option C. So there's no need for Mircera or intravenous iron because his hemoglobin is robust. You don't want to make it any higher because that's actually associated with increased cardiovascular complications. But it's worth mentioning that it's very unusual for a dialysis patient not to require Mircera or intravenous iron. Now, patients with polycystic kidney disease often fall into this category, but so do patients with a renal cell carcinoma. So a lot of kidney tumors produce erythropoietin. And as a consequence, if someone doesn't require Mircera and intravenous iron, we have to think about the possibility that they might have kidney cancer, which occurs about 4 times more often in the dialysis population than the general population. So in this case, nephrologist ordered a renal ultrasound, and lo and behold, the patient had a renal cell carcinoma, which is subsequently removed. And after that, his hemoglobin came down and he required Mircera again. Okay, it's time to summarize what we've learned today. All right, so anemia contributes to many of the symptoms associated with reduced kidney function. These include shortness of breath, and the partial correction of anemia provides some benefit. We routinely monitor all hemodialysis patients for anemia and iron deficiency. We check their hemoglobin at least monthly and their iron levels every 3 months. The treatment of anemia includes erythropoiesis stimulating agents as well as intravenous iron. There are several different erythropoietin preparations available. We currently use Mircera here at the Northwest Kidney Center. Our target hemoglobin level range is 10 to 11 rather than higher levels. Remember that levels 13 and above are associated with adverse outcomes, increased risk of heart attacks, stroke, heart failure, hospitalization, death, and access thrombosis. Remember that intravenous iron is needed in dialysis patients to maintain adequate iron levels. Complications of intravenous iron administration include iron overload, nausea, chest pain, shortness of breath, and allergic reactions, which can include anaphylaxis. There may be an increased risk of infection associated with intravenous iron. The studies are equivocal. At the Northwest Kidney Center, we hold iron for 2 weeks while treating someone with antibiotics. Okay, so now it is time for the quiz. Name 3 causes of anemia in dialysis patients. Okay, you got it. Erythropoietin deficiency, blood loss, nutritional deficiency, again, iron, folic acid, B12, and inflammatory block. Excellent. High levels of this molecule cause inflammatory block anemia. Okay, that's right, hepcidin. So hepcidin again is that inflammatory molecule which is synthesized in the liver. It's upregulated in settings of stress or inflammation, and hepcidin binds to the channel that allows iron to leave cells. And so if it binds that channel, it gets taken up by the cell, both get destroyed. There's no channel by which iron can leave the storage cells. So basically you end up with very low levels of circulating iron in the blood. Okay, what are some advantages to treating anemia in the dialysis population? Okay, improved energy, better quality of life, and decreased need for transfusion. So again, whatever we can do to avoid transfusion is of critical importance for our dialysis patients, particularly if they are a candidate for a transplant. So why is it good to avoid transfusion in dialysis patients? Okay, avoid the risk of infection, avoid triggering antibody production to foreign proteins. Again, antibodies make transplant more challenging, and the risk of iron overload. Cost, of course, is another issue. Transfusions are very expensive. Okay, last question. Um, what are some problems associated with raising the hemoglobin to 13? Okay, increased risk of cancer, increased risk of mortality, heart disease, hospitalization, access thrombosis, and blood clots. Next question, what is the definition of iron deficiency in a dialysis patient? That's right. So transferrin saturation less than 20% and a ferritin of less than 200. Remember, though, that the Northwest Kidney Center these days only uses transferrin saturation, the TSAT, in deciding when to give intravenous iron. What organs can be affected by too much iron? That's right. So iron deposition in the liver can cause cirrhosis. In the pancreas can cause diabetes. In the skin can result in a tan discoloration. In the joints can cause debilitating arthritis. And in the heart can cause heart failure. True or false? There are compelling data to show that intravenous iron administration increases the risk of infection in hemodialysis patients. Okay, and the answer is false. So again, the data are very equivocal on this, but some of the larger observational studies have suggested there's actually no increased risk of hospitalization or infectious complication. That said, just to be really conservative, the Northwest Kidney Center has adopted a policy where they don't give it for a 2-week interval while someone is receiving antibiotics. Okay, so this concludes the nephrology boot camp on anemia and iron. I hope you found it beneficial. Stay tuned for more talks in the future. Have a great day.